Welcome to this video on Meconium aspiration syndrome. In this session, we will cover the epidemiology, pathophysiology, diagnosis, and management of this critical neonatal condition. This topic presented by me, Dr. Salem Keshba, neonatal specialist. This video is structured to guide you through the definition and historical context, the significance of meconium-stained amniotic fluid, and the detailed mechanisms behind aspiration and the resulting inflammatory responses. We will also examine the clinical features, diagnostic tools like chest X-rays and echocardiography, and evidence-based management strategies, including respiratory support and prevention. Meconium is a sterile, viscid substance. While 10 to 20% of fetuses pass meconium in utero, it serves as an environmental hazard. Understanding its composition and historical context helps us grasp why its presence in the amniotic fluid is a key marker of potential fetal compromise. The epidemiology of meconium-stained amniotic fluid is influenced by gestational age. Incidence rises significantly as the pregnancy reaches 41 and 42 weeks. We also consider racial disparities and stress-mediated factors, such as maternal smoking or drug use, as critical risk contributors. Why does the fetus pass meconium? It is often driven by maturation of the gut and neurological pathways. However, stress, such as hypoxia, triggers cortisol and hormonal release, which increases colonic motility. Once passed, gasping efforts under hypoxic conditions can pull this meconium deep into the airways. Clinically, we classify MAS using several frameworks. A common approach involves identifying respiratory distress in infants born through meconium-stained fluid when other causes are ruled out, often supported by specific duration and severity criteria. The pathophysiology of MAS is complex and multifactorial. It is not just airway obstruction. It involves non-inflammatory mechanisms like surfactant inactivation, a massive inflammatory response triggered by meconium, and the development of pulmonary hypertension. Obstruction can be complete, leading to atelectasis, or partial, creating a ball valve effect that causes hyperinflation and air trapping. Additionally, meconium directly impairs surfactant function, further compounding the risk of atelectasis and edema. The inflammatory response in MAS is intense, with meconium acting as a potent chemotactic agent. This, combined with pulmonary hypertension, often due to in utero vascular remodeling and sustained vasoconstriction, creates a dangerous cycle of hypoxia that requires vigilant monitoring. The classic clinical profile includes a post-term infant born through thick fluid, often with depressed APGAR scores. Clinical signs range from tachypnea and grunting to a barrel-shaped chest. Severity is stratified based on oxygen requirements and the need for mechanical ventilation. When diagnosing, we must distinguish MAS from mimics like transient tachypnea, pneumonia, or congenital heart disease. Diagnostic tools such as dual saturation monitoring, echocardiography, and careful interpretation of clinical signs are essential for accurate management. Chest X-ray interpretation in MAS can show patchy infiltrates, hyperinflation, and air leaks. However, clinicians must be aware that X-ray findings do not always correlate with the severity of respiratory distress. Lung ultrasound is also emerging as a valuable, radiation-free bedside tool. Initial diagnostic tests include continuous pre- and post-ductal saturation monitoring to identify PPHN. Blood gases help guide ventilator adjustments, while CBC and inflammatory markers assist in differentiating MAS from other infections. In summary, MAS management is stratified by severity. Mild cases may require minimal intervention, while severe cases necessitate mechanical ventilation and PPHN therapy. Recognizing risk factors like fetal distress and thick meconium early is crucial for improved outcomes. Moving on to the respiratory management of MAS, the primary goals are to maintain stable oxygen levels while avoiding both hypoxia and hyperoxia, ensure adequate carbon dioxide clearance, and implement lung protective ventilation strategies to prevent or manage persistent pulmonary hypertension. For respiratory support, options range from supplemental oxygen and CPAP in milder cases to conventional mechanical ventilation or high-frequency oscillatory ventilation for severe distress. Additionally, surfactant therapy and inhaled nitric oxide are key interventions used to reduce illness severity and the potential need for ECMO. Managing PPHN and providing adjunctive treatment may involve specialized medications like sildenafil or milrinone. In refractory cases, ECMO serves as a last resort, with therapeutic hypothermia, vasopressors, and careful fluid management supporting stabilization when indicated. Prevention strategies have evolved. We now emphasize obstetric measures like avoiding post-maturity and identifying high-risk pregnancies, while shifting away from routine suctioning. Delivery room management focuses on assessing vigor, and postnatal strategies center on early surfactant and prompt NICU admission. To wrap up, remember that MSAF is a fetal hazard, and MAS is multifactorial. Screen for PPHN in severe cases. Be aware that clinical severity may not match X-ray findings, and note that modern treatments like surfactant and INO have significantly improved outcomes for affected newborns.